I'm going to share, and I'm going to share a PC. There it is. Y'all been waiting on it. Shoulder girdle, humerus. This is on page, what, 211? I think we're going to start out. Is that right? 211. All right. I'm going to run through it kind of quick. It's just a little bit of anatomy here. Essential projections for the humerus is going to be the AP and the lateral, and a lateral for known suspected fractures or trauma. Transthoracic, we'll talk about that in just a little bit. This was on page 144. Yeah. Okay. What's unique about the humerus? You guys know this because I drilled it in your head. What classification? Long bone. What was some other long bones that you've dealt with? Everything in the what? In the hand was considered a long bone. Even the very distal phalanx was still considered a what? Long bone, because it still had the same characteristics of what? What's the description of a long bone? Head base and a long cylindrical shaft. Y'all remember that? Here it is again. Okay, so the long bone is, and we also call it the humerus is known as the arm. Did y'all know that before you got into radiology? I didn't. I just thought this whole thing was an arm. But this is forearm. Y'all been tested over. Now this is the arm. So the humerus is the arm. So when we say arm in radiology, we're strictly talking about the humerus. All right, the head articulate with the scapula to form the shoulder joint. Everybody got that? Because we have a shoulder girdle. And a girdle is something that wraps around and protects it. And that's going to be what? Clavicle and scapula. Shoulder girdle, shoulder joint. All right? The distal end forms the elbow joint. You know all about the elbow. All about the elbow. What do you know already? Medial and lateral epicondyles. We'll be using them again. They're coming back. All right, proximal head, proximal anatomy. We have the head, anatomical neck, surgical neck, and we have the greater and lesser tubercle. If you don't know what they are, you need to go back and you need to look for them, because you're going to be using the greater and lesser to determine which view of the shoulder you're looking at. And that's all about the placement of the arm. Internal, external, or neutral. That's coming up. So you'll have to know that. You'll have to be able to look and say, well, that looks like the greater, this looks like the lesser. There are actually two little bumps, and then there's a little trawl in the middle of them called the intertubercular groove. I call it the bicipital groove. When I was in school, that's what they called it. But it's this little groove right there, like that little ditch, like two hills and this little ditch in the middle. That's what you have to focus on as far as the anatomy of the shoulder. You have to know that. You have to be able to look at the image and see, is the greater or lesser being demonstrated? And that's going to tell you the rotation of the what? Whole arm. Okay? Any questions on that? I can tell you there's a surgical neck. The surgical neck is actually the weakest point. If I'm saying it right, maybe the anatomical. And so I'm going to go, surgical neck is the weakest of the areas on the shoulder. So that's more likely to be the area that's going to get fractured if we have any type of shoulder injury. All right, greater tubercle, tuberosity, the head, intertubercular groove. This is looking at it from a different view. There's your surgical neck, lesser tubercle. Here's your bicep. Yeah, they got bicipital groove. Here, there's the head articulating with the glenoid. Deltoid tuberosity. You don't need to know that, but you do need to know the body. All right. On the distal part of it, and you should know this. Do I need to go over it? You should drill this in your head from a what view? AP elbow, right? You've seen it. You've looked at it. Capitulum, trochlea. You know those. There's your friends, the condyles. Medial and lateral. You should know those. So we're going to be using those quite a bit. That's really the only thing you need to know on the elbow is your medial and lateral epicondyles in relation to the arm. Okay, AP Humerus, this is on page 211. We're going to actually start using the book now. Let me see if I can get my book to come over with us. She got me all, I was telling them earlier, I don't know if you heard me, my student worker got me all messed up. She has the wrong edition highlighted. So I don't know what I'm doing here, but I'll wing it. Okay, AP Humerus is on page 211. And at the very top it says the shoulder and arm abnormalities, whether traumatic or pathological in origin, are extremely painful. Column 1, top of the page under upright. For this reason, an upright, either standing or seated, should be used whenever possible. Does it say it always has to be? No. But it's just telling you if the only thing you have injured on the body is your shoulder, the less painful thing for a patient to do for you is to stand up. Because they're going to stand up and they're going to hold their arm over their stomach and they're protecting this whole movement. When they lay down, guess what? Kind of like falling backwards, the pressure of laying down pushes the shoulder forward. It's painful. But if you got a messed up shoulder and you got a broken knee, good luck standing them up. Because now you're dealing with two completely separate images. So you can do this on the bed, on a stretcher. Okay, but remember, the preferred is the what? Upright, and then you ask yourself the question, why? Come on, Hannah, why? Less painful for the patient, exactly. There is a preferred method for everything. Your test questions will say preferred. So your answer will be upright. Even if supine, recumbent, stretchers, your choices, what's the preferred? Upright. And you have the reason why. Anytime in radiology there's a question like upright or something like that, ask yourself the next question, what? Why? Because your answer, you get 2 questions out of that. Get 2 questions on your test out of that. All right? Let me think. It says should be whenever possible. With rotation of the patient's body as required, the arm can be positioned quickly and accurately with minimal discomfort. It's so much easier to rotate a patient, turn a patient. Can y'all see me? Yeah. So when you're standing and they have an arm injury, it's so much easier. Look, just turning, getting them to turn. If that's the only injury, it's so much easier to position it. But when you're on the table, then you got to start rolling them up. Y'all did transfers, right? Using sponges and things like that. It gets kind of painful. And like I said, just for them to lay flat on that hard table when they have an injury to the arm, it's pretty painful. But if you have other injuries, you have no choice. They got ran over by a train. I mean, there's nothing we can do. We have to do what we can with portables, laying down, get the best images you can. All right. On position of patient on 211, same column, very last bottom. It says the body position, whether oblique or facing toward or away from the IR, is unimportant as long as the AP radiograph of the arm is obtained. Everybody find that in the book. Same column, bottom of the column. Highlighted. Test question. If you can't do something AP, you can always do it what? PA. Can't do something PA, you can always do it AP. Did y'all know that? They're just mirror images of each other. All right. That's the only thing I have on the page highlighted, but I do want to talk about position of part. Let me see how my PowerPoint's going to run. All right. Part position, place at the top of the IR. This should mirror your second column. Place at the top of the IR in light field approximately 1.5 inches above the shoulder, the humeral head. You need to make sure you see light above here, right? Because you're going to get way up here from the AC joint all the way down below the elbow. So when you get them onto that board, make sure you have light above their shoulders, not skimming it. Put you 1.5 inches light above there, just to make sure you get it all. Okay? Slightly abduct humerus from body and supinate hand. Abduct means to what? You want to pull it away from the body. This is going to be an AP humor. I don't know how much y'all can see. Can y'all see me now? So this is AP, right? We don't want this, right? What's wrong? It's too close to the thorax. So it's slightly, not dramatic. And I've seen a lot of people do dramatic stuff. Really pull it out. That's not what we want. Just so that you have some space here to separate it from the thorax or the abdomen. Okay, slight abduction. The coronal plane passes through the epicondyles. It should be parallel with the IR plane of the AP. You should understand that. No problem with that. You've been tested on it. Many of you got it backwards. And it's so easy to do. So easy to do. All right? A coronal plane passing through the epicondyles. What does a coronal plane do? Divides the body into anterior and posterior equal halves. Isn't that the definition? Yeah, this come from intro. So this is what they're talking about. AP, a coronal plane this way, cutting through them, not going between them, going through them. And it becomes what? This plane is now what? Parallel. It's flat. Y'all get this? Or did you think this? This is going between the epicondyles. This is passing through them, like you're cutting through them, anterior, posterior.
Mr. Delasar.
Yes, ma'am.
We only have one screen here, so we can't see you. We can only see the PowerPoint.
You don't see the preview screen?
No, because we only have one projector. It's in the projector room, so there's only one screen.
Well, that's all we have too, but in the bottom corner, I'm in the bottom corner of the screen.
Hold on, let me see if I can change the view.
Well, it'll be in our recording, so
hold on.
you have to go to camera and turn on your preview bottom corner.
Look, I done figured out some stuff I can do here.
You need to keep that on. That keeps the instructor in your PowerPoints. When you see this again, I'm still stuck down there driving you crazy.
Yeah.
All right, Miss McKnight, you okay?
Yes, sir. Thank you.
All right, coronal plane passing through. Y'all got that? Passing through, not what? Between. Between means you're doing what? This. But you have to go back to the plane they're identifying and saying, what is the definition of a coronal plane? Divides the body into equal halves, anterior to posterior. Do the same thing with the elbow. Here's my plane, coronal. This is my anterior. This is the posterior. It's cutting this way. That makes it what? Parallel. Everybody with me? Parallel to what? Parallel to the IR. Now it would be perpendicular to the X-ray beam. Y'all know this? I'm seeing a lot of eyes like, oh, I've never heard this before. Did they not explain it like that? Okay, all right. I just explained it like that. Did it help or did it unconfuse you? 50% missed it. And I think because you're confused on the wording in the book. It's through or between. Going between something means you're going to stand in the middle of it and you're doing what? Separating them. That's not what the book said. It gave you the plane and it told you which, by definition, what a coronal plane will do. Correct? Good? Moving on. Danielle, I like your new card. Yeah, I'll get you a black. All right. So let's see, suspend respiration. Why not? Is it going to move? Is the humerus going to move while we breathe? No. Central ray, of course, is midpoint to the what? To the humerus. Why wouldn't it be? It's a long bone in the middle of the long bone at the shaft. Right? Don't make this hard. Trust me, positioning 2 is going to blow you away. It's hard. But by then you will have learned good study skills. You'll know how to weed through a book. There's stuff in this book, it's got good reading. It's not test material. Okay? AP structure shown in its entirety. Evidence of collimation. The elbow and shoulder joints are slightly distorted. You saw that? Well, yeah, because the central ray is where? In the middle. That is the only part of the beam that has a beam. X-rays coming what? Straight down. You heard divergent? Divergent beam. You're in radiology school. You've heard of divergent beam. Is that a no? Everybody's eyes are dilated again. The big eyes. Divergent. What does that mean? What does light do? Diverge. Spread. X-ray spread. It'd be nice if we could keep them real tight and coned down like a little laser light. But they spread, and they spread what? With distance. So if you're centered to the shaft, the edges are what? They've already spread, and as they spread, they are picking up angles. So the only thing that's going to be real true representation is what? The arm. The elbow is going to be distorted, probably closed because of the angle of the beam on this part. The shoulder joint's not going to be real because the same reason. You're using x-rays that have got an angle. That's why we tell you to use the central part of the beam. Central ray. It's only the few in the middle that's going straight through. That's why when you're doing joint spaces, that central ray needs to be what? Directly over the joint. Because just that little bit of angle as they're picking up, that will close the joint space. That's physics. I teach physics. I love physics. So anyway, all right. Humeral epicondyles without rotation, humeral head in greater tubercle in profile. So look on page 211 on that image 5.152. Y'all see that? Look at the top. You see that triangular looking thing going out on the top of the humeral head? I don't know if I got it on my slide. Let me see. Too many contraptions up here. All right, this is being done erect or supine, right? All right, so this is the APA. It says entire, yep. Greater tubercle in profile. Greater tubercle, look. You see that? That is your greater. This is the what?
We can't see the mouse.
I'm sorry?
You have the mouse on it?
Yeah, you can't see it?
No.
Oh, what the hell? Hang on, let me see about what's going on with this. Okay. You see it now? All right, so what was I showing you? Back up. All right. All right, lateral. I had another one on here. We saw that, top of the border, we did that one. Now that's lateral. I hit too many things here. Here we go. All right. It's kind of, okay, look, you see this little tiny white line? That is what? Lesser. You see this big triangular looking right here? That is your what? Greater. And you can kind of see the little ditch in the middle of it. Everybody see that? So it's telling you that if the greater is what? Anytime you see the word profile, you need to stop, you need to get your highlighter, you need to highlight it. Because that is what the test question will be. In relation to the greater tubercle, which of the following is true? Superimposed, can't see it, is nowhere near, or in profile. There's your answer. Anytime you see in profile, so that's telling you when you're doing an AP humerus, the greater tubercle will be in profile. Everybody understand that? Because you're going to see this over and over and over again. All right. Medial and lateral epicondyles in profile. There they are. See the little bumps right there? Right there? They're in profile, meaning that we can do what? See them clearly without anything superimposing them. Any question? Any question? Without rotation. Humeral head and greater tubercle in profile. Outline the lesser tubercle located between the humeral head and the greater tubercle. And there's your big bony trabecular detail. How do you get bony trabecular detail, girls, ladies? Don't let me down. Say it. Small focal spot to ensure you have good bony trabecular pattern. And we're doing bone work. So we should always be on small focal spot. Very good. Point. Check. It was on y'all's lab form. Any questions on the AP? Everybody good? Not hard. Your position, and you're going to be palpating the what? Epicondyles. You're going to have the arm hanging down by the side. You're going to reach down and make sure those epicondyles are flat on the vertical or on the table. Just like what? Just like an AP elbow. All we did was change the central ray, and it's going to be up here mid-shaft, mid-arm. Good? Can we speed up? Can we speed up? You don't want me talking fast. All right.
I see a few of them shaking their head no.
They're shaking their head no?
Uh-huh.
All right. I'm going to
Steady
take
pace.
12. We're talking about the lateral humerus. On the first column I've got, first of all, it said at the very top underneath your projection name, lateral projection, it's got lateral medial or medial lateral. Those are your projections. What is a projection? In and out of the beam. So that tells you right there you can do it either AP or PA. All right. And it says upright position, position of patient. Let me see if I got any of this here. Yeah, that's the IR. Okay. It says the body patient, whether oblique or facing towards or away from the IR, we don't care. Is not critical as long as the true lateral projection of the arm is obtained. We don't care how you get there, just get there. And what they're wanting to do is to have the epicondyles what? What's a lateral elbow? It's the same thing. They're going to be perpendicular. So you're going to make sure that you have the arm away from the body and that it's a flexion. Wasn't an elbow 90-degree flexion? It's the same thing. Just make sure you can palpate them. Where you think you're going to put the central ray? Mid-shaft, mid-arm, right? Is the elbow and the shoulder joint going to be clearly demonstrated? No, because we have what we call beam divergency. We're not doing it for shoulder joint. We're not doing it for elbow. We're doing it for the arm. Right? All right. So I'm moving over. Next call. Well, position apart. It says 1.5 inches. I don't know. 1.5 inches above the humeral head. Same thing as the what? AP. If possible, internally rotate the humerus, flex the elbow 90 degrees. Sounds just like a lateral elbow. And rest the palm of the hand on the hip. This. That's what they want. This. I don't care if you do this or not. As long as what? The epicondyles are perpendicular. Coronal plane passing through the epicondyles should be perpendicular to the plane of the IR. So here we are. Coronal plane still divides the part into anterior and posterior. Here we go, going through them. anterior, posterior. Got it? All right. Is that plane not going to be perpendicular to the plane of the IR? Yes. Plane of the IR is behind me. What is it to the beam? Yeah. I told y'all that could be like 8 questions. So be careful if it's going between the epicondyles, through the epicondyles, to the IR or to the beam, because it all changes. But if you just think about the definition of a coronal plane, put it there. I see you taking your test and you're doing all this robotic. Put your plane there. And remember, it said through, not between. I haven't seen the word between yet. But on a test question, I might pop it in there just because I want to. Blow your mind. To read your question carefully. All right? Perpendicular to the midpoint, center to the IR. Here she is again. Is this the same model y'all have? Same lady? On page 212 in your book? No? No. I got this out of Bond Trainers. I just got tired of looking at the same people. So I went and got a different book and I started using different models. I got tired of it. I was so sick of looking at the little guy in his blue panties. Did y'all have him yet? Y'all have had him yet? All right. So yes, look, we can do this. This is going to be our lateral. Look what she's done to the hand. You see at the back of the hand's on the hip? She doesn't have it like this. Does it matter? As long as doesn't matter. In fact, when you get like this, it's harder to get it collimated. So I used to do mine like this, but I'm still looking to see if they're what? Yeah. And just have a little separation here. You don't have to do this. It didn't say that. But you're just making sure the epicondyles are going to be perpendicular. Same thing on the table. Abduct the arm a little bit away from the body and make sure it places by placing the back of the hand on there, you're getting them epicondyles stacked on top of each other. Let me see what else I got. The other page on 213 talks about the same thing, AP projection of the the humerus, but it's showing you in the recumbent position. Can you do it that way? When would you do it that way? Yes, you can, and probably during trauma. When the patient's unable to do the preferred, which is going to be what? Upright, okay. I'm back on page 212, perpendicular to the midpoint. Collimation field is 2 distal to the elbow, superior to the shoulder, and 1 inch on the sides. So we got 2, 2, and 1 on each side. And y'all know that's new to this book, and I'm not a fan of it. But I think I told you that. I'm not a fan of someone telling you how exactly to collimate. You need to collimate how? As close as possible without clipping any of the area of interest. That's how real techs work. We don't go in there and measure our collimation. Oh, that's 2.5. That's too much. So I've already expressed my opinions in this edition. So I think they need to take it out. But anyway, what do I know? All right. Any questions on the lateral projection? It can be done either AP or PA. Lateral medial, medial lateral. That's your projections. AP recumbent is on page 213. There's nothing different here. Let's look at your evaluation criteria. Let's see what I got. This is on page 212 evidence. We got all that. Lesser tubercle in medial, on the medial aspect, greater tubercle superimposed over the humeral head. Bony trabecular pattern. There it is again. Superimposed humeral epicondyles. All right, so here we are. Entire humerus is demonstrated. Look at the down here at the elbow. Looks just like a lateral elbow, doesn't it? Epicondyles are stacked on top of themselves, right? And it said the what? Lesser is in profile, and the greater is superimposed by, it's under the humeral head. Everybody's seeing that. It's not, you don't see that triangular anymore. Remember how we saw that big triangular thing coming out? We'll see it better when we get to the shoulder. But remember, we're not doing this for the shoulder joint. This is for the what? This area right here. Okay? Everybody good with this? Lesser tubercle in profile, yes. The epicondyles, the entire thing's demonstrated, yes. All right. let me see what she's got here. Let's flip over on is it 236? Transthoracic. Yeah, there it is. All right, let me go ahead. Let's get this one over with. This is a trauma view used for the proximal humerus when you cannot get the patient to abduct the arm away. All right, and this is on page 236, transthoracic lateral. So I guess she put it here because she wanted it directly behind the lateral humerus. So she played, but she said it was a mess and she cleaned my PowerPoint up. So this is my first time seeing it. So we'll go with it. All right, trauma view. So we have transthoracic lateral as our Darcy. What is that? Transthoracic lateral. What am I giving you? Transthoracic lateral is the projection. That's all I was wanting. Where's your thorax? Chest. Trans. Across. If you took medical abbreviations, medical terminology, that means we're going across the what? Transthoracic to get to the arm. Pretty cool, huh? So this patient we can't lift it, we can't do nothing, it's just a mess. This arm's good. So we leave the injured arm dangling. We work to get the good arm out of the way, whatever you can do with it, out of the way, and we're going to shoot through the thorax to get to the humerus. Trauma view. Everybody with me? What's the projection? Transthoracic, and it is a lateral perspective of the proximal humerus. So all you're going to get is this up here and the top part of that. You can get a distal trauma view, the lateral. That's easy. All right. So it says this Lawrence method is used when trauma exists and the arm cannot be rotated and abducted because of the injury. This method results in a projection 90 degrees from the AP projection and shows the relationship between the proximal humerus and the scapula. All right. Let's see what else is got on here. It's 236, scapula, humerus seen through the lung field, scapula superimposed on the T-spine, the unaffected clavicle and humerus above the shoulder of interest. All right, I'm going back to 236, position apart. Although this projection can be carried out with the patient in the upright or supine, the upright position is much easier on a trauma patient if that's the only injury they have. For upright positioning, sit or stand the patient in the lateral position. If an upright position is impossible, place the patient in a recumbent position. And it says you can actually put a little sponge or something underneath them just to elevate the entire thorax so that you'll have some clearance and you're not skimming the bottom of the table. So we want to put a sponge underneath them to elevate them. All right. Anybody have any questions? Y'all can stop me because I have a tendency to ramble a lot. Everybody keeping up okay? All right. This is on page 236 also, showing you your same two images. Little guy in his blue panties. So we have the erect transthoracic. You notice the unaffected arm is brought up and over his head, pulling that humeral head of the unaffected arm up. And what we're going to be doing this. This is the injured arm. So we're going to encourage them to do what? Push this one down. We're pulling this one up. We're trying to separate the humeral heads from each other. So this one's going to be up, and we want to push this one down. Zoria, don't jump on that man's shoulder and pull that arm down, because I know you will. We don't manhandle. We encourage them. Can you push this down? Even if they go, maybe taking a deep breath, and as they exhale, that helps. So there's some little tricks that we'll learn. But the idea is to get this one down, this one up. And we're going to shoot through this. Is this going to be a problem? It's a yes or no. Hands up, yes. Hands up, no.
We had a no.
We had nothing. What's wrong with y'all? Is this transthoracic, this chest going to be a problem? Yes or no? Answer the question. No. We wouldn't be doing it otherwise. Think about this. This is science. Dear God. Whew. I'll get a drink. What's in the lung field? What's in the thorax? Just gave it to you. Made out full of what? Is that a problem to penetrate with an x-ray? Thank you. Dear Lord, oh Lord. All right. So let's see. We're on patient position apart. Raise the middle column. 236. Raise the non-injured arm. Rest the forearm on the head. Elevate the shoulder. Elevation of the non-injured shoulder drops the injured shoulder, separating the shoulders to prevent superimposition. Ensure that the mid-coronal plane is perpendicular to the IR. No attempt should be made to do what? Rotate or otherwise move the injured arm. Otherwise, you wouldn't be doing a transthoracic. If they can move the arm and get it out of the injured arm, move it and all that, well, why are you doing a transthoracic? This is normally when they come in and they have the shoulder strap on. I can't remember what it's called, but it's fixed. They can't do it. So they got it kind of strapped to their stomach. So that's what this comes into play for. All right. It says center the IR to the surgical neck. Remember I pointed that out to you earlier. I told you that was the weak spot of a humerus. So this is the central ray. It's just a little bit below the humeral head. All right. So it says at the surgical neck area of the affected humerus of this one. So you're eyeballing the affected, right? Everybody with me? And you're going to be standing here. This is what you see. This is what you're centering to. So you have to kind of stand in front of them and looking for this shoulder. So I stand behind them and push them forward a little bit. Don't center them. Nothing to do with this because this is supposed to be up and out of your what? Way. All right. Respiration. Full inspiration. Why? You get air in the lungs. Air is going to be what color? What? Bone is white. Air is black, meaning full x-rays got through. Nothing was attenuated. Bone attenuated, got weaker, turning shades of gray. So we have lots of black, and we have this beautiful white bone in the middle. What is that called? High contrast. Black, white. High contrast, the two extremes. We just created high contrast. Going to make a beautiful picture. It's got all black around it, and here's your humeral head with a little bit of the proximal shaft. Everybody good? And another thing, when you're filling up your lungs, the pleural cavity actually thins out just like a balloon. So it's even easier to penetrate when you're fully inflated. Make sense? You seen what a balloon looks like after you've blown it up a couple of times? It wrinkles all up. Then you blow it back out. What does it do? Stretch and thin out. That's why we want that full inspiration. But remember I told you a little trick. That you just can't get those shoulders to move like you want them to. Disregard this. It's going to have contrast anyway. Because lungs always have what in them? Some amount of air or you're dead. Right? So remember I told you you can actually take a deep breath in and what? blow it out, and as you blow it out, the shoulders have a tendency to drop. Because when you take in a deep breath, what happens? The shoulders are going in the opposite direction, but if you have good separation, it doesn't matter. But if they can't get it like that, so I know another way of doing this. I know you're going to have some air in your lungs. They won't be hyperventilated, right? Hyperinflated, but it's okay. So there's always little tricks you'll learn as we go through this program. Those are the little things you want to pick up and put in my little trick book. Everybody got one? Mr. Spino told y'all to go buy a little address book. I heard her. When you're told to do something in this program, you do what? You do it. She told you to go buy a little book. Go buy the little book. They're 67 cents. It's the most important. I still have mine from school. We call it our personal Bible. That's where you write all your little things that you want to remember. I would have put this probably under the S for shoulder. That's why I like the little address books. It's got the alphabet. All right. Having the lungs full decreases exposure, improves contrast. Over on the third column, if the patient can be sufficiently immobilized to prevent voluntary motion, a breathing technique. Holy cow. A breathing technique can be used to blur the pulmonary vascular, how do you say that? Vascular, I can't say it. In this case, instruct the patient to practice slow breathing, a minimum exposure time of 3 seconds. That's a lot, guys. We work in milliseconds. This is 3 full seconds. It's like, bonk. You're hearing radiology, beep. Okay, that's millisecond versus a second. 3 seconds. Okay, this is going to give you a very long exposure. All right, it says 3 seconds, 4 to 5 seconds is desirable. I think 4 to 5 seconds is a little extreme. I normally go with the 3. I think that's long enough if they can do right. Gives excellent results with low. You have to set your MA to a very low setting. Because what gives you mass? Combination of time and MAS. What gives you mass? MAS. Time is the S. You only have 2 letters left, and it's what? MA. MA times time is mass. Y'all learned this in intro? Miss McKnight taught y'all? She's right there. I could easily ask. I know she told y'all this. All right. Central ray, again, it says perpendicular to the IR entering the mid-coronal plane at the level of the surgical neck. Same thing as the other one. No difference. The only thing that we need to focus on is, and it is a good idea, when you're doing this position and you just can't get the arms separated, you can throw a little angle that will project this down and this up, whichever way. I don't know, are they using this cephalic? I've done them both ways, depending on, it says cephalic. So if you go up, you're going to angle, you're trying to get this shoulder to be up. So that little angle will help out. It's not the most common thing to do, but that would be a very short, obese person that just has no reach, and you're trying to separate their arms. So you might consider doing a little angle. But again, that's not normal practice. Is it wrong? It's in the book. So it's not wrong, but it's not what we're accustomed to doing. All right. Structure shown. I want to get to the breathing. Where's the respiration? All right. If the patient, sufficient case, okay. They don't even tell you how to do it. So it says breathing technique. So what is the patient going to be doing? Huh? Breathing technique. Breathing technique. They're breathing. That goes against the grain of radiology. We normally tell patients to what? Hold still, don't move, don't breathe, hold still, don't move. Right? What are we telling this patient? Breathe. And it's not normal, but it's going to be breathing. So we have to do this as our instructions for this exam. We want the motion to be fast. Because we're trying to what? Create movement. What moves when we breathe? The lungs, the chest. So they're like this, right? I should say this. This is the hurt shoulder, but I'm trying to flip it for you. All right, you're like this. This injured shoulder is actually pushed into that board, so it's stabilized. Okay, this arm is not going to move. This arm is up. What's moving? All this here is going to move. That's going to cause motion. All that blurs out. And you have a beautiful humeral head. I do them all the time. I love breathing techniques. So you're going to use a long what? Exposure time. Because normally we work in what? And now they're telling you to use at least 3 full seconds, 4 or 5 they even suggest, right? So if that high or that long of a time, you have to use a very low, not mass, I'm giving mass a time. Losing it. Mass, MA times time. I'm giving you the time. It's 3 seconds. What's left? Milliampere, MA. You have to choose an MA station that is low. Y'all see this on the control panel? MA times KVP. Are you seeing mass or are you seeing the MA and the time? There's a button you have to push next to it to break mass into its 2 components, which is an MA and a time. I'm telling you, set your time at 3 seconds. That's long. That's a high time. So we need a low MA station. And I'm talking, y'all are used to using 300, 400, 150, whatever y'all been telling me. I'm talking 25 MA, 32 MA. Because 32 MA times 2 seconds is still 64 mass. Right? 40 MA at 2 seconds is 80 mass. 1 at 80 is 80 mass. Are y'all with me? Y'all look completely either lost or blanks. I'm trying to figure out where we're at. Where we're at, Tessa? Where's your mind? You're right with me. You own it. You own it. All right, Chelsea, where you at?
No.
You're not on this. All right, let's back up. What are you not on?
I just came out from the bathroom, so I missed a little bit.
I don't care. Where did you leave off on your tablet? We're talking about breathing techniques under a transthoracic. Do you know what a breathing technique is? How's the patient going to be breathing first of all? No. I always tell them pant like a dog. Everybody knows what a dog looks like when they're panting. That's what you want. If you don't, it's not breathe regular. Why do it? You might catch 1 respiration in that 2 seconds, right? You want them to move those lungs because that's what we're allowing that to do. What's going to happen to the lungs because they're moving? They blur out. What doesn't blur out? The humeral head of the affected shoulder because you have it pressed against the what? Bucky. Everything else can move. We want it to. We want it to blur. But we have to give it enough time to blur. That's why the 1 second won't work. You can't do anything in 1 second. So they say, I say 3. Like I said, I've done 2 before and it worked out great for a sternum, but here at least use 3. I'll post something for y'all this afternoon. It's called the reciprocity law. Won't get into it, but it's physics, but y'all need to know about it. There's like 700 ways to get to a total of 64 mass. And I'll show you how to break it down. As one goes up, as your time goes up, the other MA has to come down. As your time gets shorter, your MA station has to go up. But the output is the same. Long exposure, a little bit coming out, a lot coming out, a short exposure. And what we want right now, we want a long exposure, so we want very little coming out because it's going to stay on longer. Chelsea, where you at?
I'm with you.
Are you sure? What page am I on?
236.
All right. So we're looking over here on page 237. All right. And we're going to look at evaluation, evidence of proper collimation. Who cares? Presence of a marker. Who cares? Clear of anatomy. Who cares? Those are all what? They're required in radiology. So don't bog your mind down with that bullet. You know you have to collimate. You know you have to put a marker. The marker can't be in the anatomy. That's with anything you do in radiology. Don't put that bullet on your, whatever your little study guides are. Don't focus on that. All right, scapula, clavicle, and the proximal humerus seen through the lung field. That's what you did it for, right? That's the important part right there. Scapula superimposes the thorax. Unaffected clavicle and humerus projected above the shoulder closest to the IR. Look at here. Y'all see the two clavicles? See the V? Right there. This is our what? Humeral head of the affected one. The other one is way up here above, they're way up here above their head. But because you know that this scapula is going to articulate with what? I'm sorry. This clavicle will articulate with what? AC. The acromion of the other scapula. So you know this is going to the shoulder girdle of the opposing, the uninjured. Does everybody see the Y? This is called the affected clavicle. This is called the unaffected clavicle. Unaffected clavicle should always be what? Up. Because it's going up with the shoulder girdle of the unaffected arm. You see the
Mr. Delasar, we have a question.
Yes, ma'am.
Okay, I just wanted to clarify for the exam, do we need to know both breathing methods, the full inspiration and the
Absolutely.
panting, or is there one? Okay, so no both for this particular criteria.
You have to know both because they're listed in the
Okay.
book.
I didn't see the panting in the book, and maybe I missed it. That's why I was asking.
I told you it wasn't in here, but I told you pant like a dog. It used to
Right,
say,
I wrote it in.
it used to say shallow
wanted to-
breathing. Now I don't even know why they took that out of here.
Right. I just wanted to clarify to make sure that I studied correctly.
Yeah. You need to know them both. You can say shallow breathing if you don't want to say pant like a dog. I use pant like a dog because it's common knowledge and you're dealing with common people. You're not going to be x-raying all medical people. Shallow breathing, what does that mean to you? Does that make sense? Not deep, but shallow. So you can say shallow breathing. That works for me. Or if they're looking at you confused, you know how a dog looks after they ran for a while? They pant. That's what I want you to do. We have to get the lungs moving at least a couple of times within those 2 to 3 seconds. Otherwise, don't do it. And the one thing, and it's a good question, one thing you want to do is evaluate Granny. If Granny's on O2, I doubt she can pant like a dog. So don't go in there and say, oh, Granny, I'm going to turn you O2. I need you to pant. I didn't say that. You have two ways of doing it, right? A full inspiration of the lung creates a beautiful black cloud around the humeral head. Do that one. I just think the blurring turns out so much prettier because it blurs out everything. And it's just this beautiful humeral head right in the middle of just this cloud around it. But always evaluate your patient. Walk over, talk to them, tell them what you'd like to do. Tell them why. It's a prettier picture. Can you pant like a dog, Granny? No? Okay, we don't go there. Take in a big, deep breath, hold it, beep, I'm done. Best I can do. Granny couldn't pant. All right? So this is where you use what we call critical thinking skills. He's crushed. He got ran over by a tractor. One lung's crushed. Can he pant? He probably is. He's probably gasping. So I don't want you going in there and saying, I need you to pant like a dog. No, you don't do that. So again, just use your judgment when you're evaluating a person. And see, I was going to just ask them. Because it's going to be a what? A long exposure. And long 2 to 3 seconds, not really, but yes, it is. But they have to get a couple of those in the 2 to 3 second exposure. Otherwise, you may as well just tell them to take in a deep breath, hold it. So you do have 2 different ways of doing this. And yes, I do want you to understand breathing technique. And yes, it is on evaluation criteria. I have an image of it, and I said, what's the breathing? And I want you to action. I told you, I want the exposure factors. I don't want you to say pant like a dog. I want the exposure factors for a breathing technique. What are they? Come on, Lillian, what are they?
The exposure factors?
Hmm?
The breathing technique. It's a longer exposure time.
Long time and a low
million.
MA. Very good. Very good. 32 at 2. All right, let's see what else we got here. What's coming up next? Any questions on the humerus? We did AP, lateral, and we did trauma view, transthoracic for the humeral head and the proximal part of the humerus. I think I want you got the, now there's a little project. All right. I'm going to stop it here to make you a small recording, and we'll start back up. All right, just take a second. All right.